Hey friends, welcome back to the You Are Not Broken podcast. Today I have the ultimate pleasure of having Dr. Sharon Malone on, who I am fortunate enough to have found as a friend in this journey of mine. She has decades of experience as an OB-GYN in the Washington, D.C. area, and she's nationally known as an expert in women's health and a vocal advocate for menopause awareness and evidence-based information about hormone replacement therapy. She's the chief medical advisor at Alloy Women's Health, and you were before that a partner at one of the oldest and most successful OB-GYN medical practices in Washington, D.C. Thank you for coming.
Thank you for having me, Kelly.
I'm so glad you're here.
Me too.
I'm just gonna sit in silence and enjoy the presence of Dr. Sharon Malone.
Oh, you know what? We're going to have fun. See, this is the good thing too. Timing is everything. And to do this now, we actually know each other, so we can.
We're gonna have a little more fun.
We can go there on a lot of places,
Totally. Tell us how, in your journey, how you transitioned from traditional OB-GYN practice to the menopause world where you are now.
Well, you know what? I wish I could tell you I had a master plan. I did not. But, there is a certain evolution of an OB-GYN practice. In your early years, you're doing everything. You're delivering babies, you're doing surgery, all of that. But then you raise your kids, and I think it was right around the time my kids were middle school age. And middle school age for me, for my children, because I started late, was right around the time that you're sort of entering that perimenopausal window. And you realize that you just can't do it all. You can't do it all well, let's put it that way. And I was probably in my mid-40s. I said, I'm going to have to dial back something here, and I can't give the kids back, so I better figure out the work situation. And, and I started doing GYN. And when I did GYN only, at that point, about 15 years into my practice, you've actually watched your patients progress. You've watched your obstetric patients from 15 years ago now enter this perimenopausal window with you. And so that's when I took a shift, in my practice, dropped the OB, and then did a lot of midlife women's care. And then I did that for the next 15 years. And, to leave clinical practice was really not something I had in mind to do. But, COVID happened. And when COVID struck, and I'm sure you can appreciate this, Kelly, for the first time in, I don't know, maybe since I was in high school, I had 3 months off in a row. I've had 3 children. I'd never had 3 months off in a row. And when you sit still for a minute, you get a chance to think, and you're quiet, and you say, well, what is it that I really want to do? And, after having been there for 30 years and having 3 months off, I realized I don't hate this. I don't hate being off. I was like, okay, let's try something else here. And my husband and I talked about it. And after that first summer of COVID, I decided, I think I'm done. And I put in my resignation at my practice, and I left at the end of the year, and I had no plans. So let me just disabuse everybody of the notion that, there's a master plan and you're just following it. I think that the universe will bring you things when you are ready to receive them. And it was at that time, totally randomly, that Ann and Monica from Alloy Women's Health reached out to me. When I tell you, I have never met these women. One lived in New York, one lived in Rotterdam. And they came to me and said, oh, we're looking for a medical officer. Do you think you might be interested? And I was like, maybe. And that was the beginning. But I wish I could tell you, yes, I was executing a well thought out plan. I was not.
Dude, it's such a sound company. They're doing so much for so many women. And so I'm just like, I can't believe they found you. Like, they struck gold.
That's how the universe works, Kelly. I mean, and the story about how they found me, right?
No, tell me the story.
Oh, I'll tell you how they found me. Well, it's COVID, right? So it's the first summer of COVID, and my friend Michelle Obama had just started. She was just starting to do her podcast, but it was COVID, so everything was shut down. And I'm sure she had in mind some much more illustrious guests for her first podcast. but it was COVID, so nobody could go, and we hadn't quite figured out the remote thing yet. So I was here, and she was here, and a few other girlfriends. And so she decided, okay, well, we've got to do this podcast. And we socially distanced. She said, we had been talking about menopause for years. And she said, well, let's talk about menopause. I said, okay, let's do it. We recorded that podcast. It went out, and Michelle, who is really what I will credit her as being one of the first people who really honestly talked about her menopausal journey. And that podcast, Anne and Monica heard it, and they said, oh, we're looking for a medical director. Maybe we should find her. And just tracked me down, cold called me, and the rest is history.
That's incredible. Tell us, I think there's been some fits and starts and some physicians who I feel are very threatened by telehealth. But really, when you think about it, our healthcare system is so jam-packed full. If you think about, 75 million menopausal women who need help, who need care, it's really providing access that is not available. Because I know now you are a big proponent of telehealth platforms. Can you give your perspective on that?
Oh, absolutely. I think telehealth is the wave of the future, and we in medicine are late to the party. I think that one of the problems with medicine and our access problem is that we are still trying to practice medicine like it's 1924 and it's 2024. I mean, this model that we use is inefficient and ineffective for most people. I mean, we've got an access problem. We've got too many women, not enough doctors. That's number one. And if you could figure out how to leverage the expertise of a few over the many, that would be the answer to some of our access problems. And let me say this is not the concept of being able to do something like telehealth is something we thought about in our practice, 10 years ago. Here's the problem for most independent physician groups. Maintaining a network like this and trying to get the content that you want to get on whatever your platform is, even because we had a website and it would wouldn't it be great if we had all this content on our website? It's expensive, it's hard to do, and that's why most doctors don't do it. But it's a great idea. And the only thing about it is, you wish that, other doctors in their practices had the ability to do that, because it would save them time, huge amount of time.
Huge amount. And for people that don't have to find parking and childcare and, all the things. The big thing's the payers. The payers are saying it's not worth it. Medicare keeps kind of threatening to roll the COVID telehealth back. I don't think it's established yet that it's going to work in traditional medical practices.
Right. And you know what? And it's a licensing problem, because when you do telehealth, I'm only licensed in, DC or wherever, most doctors are only licensed in the jurisdiction where they actually practice. Now, oddly enough, that's a regulatory problem. That's not that's a matter of someone saying, that we should be able to do this in a way that's effective, that will allow doctors to practice. And that's why I said there are a lot of things that are in our way that have nothing to do with the actual, does this work? Yes, it does. And when they lifted the restrictions during COVID, where you could practice, across state lines, I think a lot of people got care that they needed, because think about how many people decamped to other states during COVID and still needed to be able to be in touch with their doctors, and telehealth was really the only way to do it.
Yeah. I mean, and it really is regulatory. Like, medicine's not different in Tennessee versus Florida, right? As opposed to law. Like, some law it makes sense, they've got their different laws, but blood pressure is blood pressure, no matter what state line you cross. It makes sense to me. I hope that as a country we can really work on providing access, because access is a huge problem in this town where I live. And I live in a pretty well-to-do town. You cannot get in and see a primary care doctor for at least 4 months, neurology for 6, cardiology for 4 to 6. Like access is a huge problem. And now you and me and our team, we're educating women to go in and seek help for menopause symptoms. It's like we can't absorb, the extra bodies.
Right. I mean, even if you could find someone that actually knew what they were doing, because that's a problem too.
Yeah.
We have a dearth of physicians who really, know how to treat menopause. That's problem number one. And when you do find someone that does, the waiting list is months long, months long. And, I don't think that physicians should feel threatened by this, because the reality is that what we are trying to do in a telehealth environment is that this is a value added. You still need to see your doctor. I mean, we're abundantly clear about that, because there are things we cannot do in a telehealth environment, but there are things that work really well. And so, as I say, help me help you. This makes your job a little bit easier, so
Yeah.
you can really focus on some of the difficult things that we can't address, and you don't get clogged up with all the things that we can address in telehealth. So
I love it. One of the things I've been dying to talk to you about is I need to talk to you about the 10 years post-menopause, age greater than 60. My number one listened to podcast episode is called The Boomers Should Be Pissed. This is a huge group of individuals who missed the boat through no fault of their own because of the Women's Health Initiative. And my listeners are decently savvy. We can go into kind of what that was a little bit, but by and large, they know. But my 65-year-olds, my 68-year-olds, my 73-year-olds, they're coming in. My 58-year-olds, they're coming in and they're saying, my doctor says I can't start hormones. And I want to dispel the myth that it's a hard stop after that 10-year window. Do you want to speak to that?
sure. Let's say this. I think that, that's where the conversation starts to go off the rail. Anytime a doctor says you can't have this, or you mustn't do this. Because I think for women, and this has always been my point of view, women are capable of making decisions for themselves. Now, I can give you the pros and cons, and there is no doubt from the data that we have now that the earlier you start hormones, the benefit ratio, the benefit to risk ratio is much higher. So yay, you get more benefit and fewer risks. But remember, the study upon which all of this is based, the Women's Health Initiative, had women in it who were anywhere from 50 to 79 years old. And the average age of these patients was 63, and it was heavily skewed in the over 60 crowd, heavily skewed. So let's take that for a moment. And even if you look at the Women's Health Initiative, the harm in that study was still not that great. That's the point, So, when people said, oh, you can't have it, it's like, well, you were giving it to 65-year-olds for 6 years during that study. And people were not falling out left and right. I mean, there was still some benefit, even in the women who were on average 63 years old. So that's number one, that we keep drawing lines in the sand like we know the answer. We don't. I think after 60, then the conversation becomes a little bit more nuanced, because it depends. If you're 65 years old and you're still having hot flashes and you're bothered, then you know what? Let's look at your cardiac profile. Let's see, are there other reasons why medically it would not be a good idea for you. But there's no hard and fast line in the sand. It just requires for you to understand what the risks, what the benefits are to you, what are your treatment goals. And if you understand that, then you should be able to take a medication. And here's the other thing, Kelly, that I think is just it's interesting to me, and not in a good way, but it's interesting that there is no other medication that has engendered this much conversation about risks and benefits. I mean, I keep saying to myself, all right, statins have risks and benefits, and yet they're handed out like M&Ms. I mean, you get a statin and you get a statin. I mean, there's a risk-benefit profile of every medication that you take. And the amount of airspace that's been taken up about the risks of hormones almost exclusively, not taking into account the benefits is pretty interesting. And I have a theory. I don't know what it is. I don't know that it's true. Look, I don't know it's true, but I do know it's true. That it's something about how we treat women. That women need to be protected and told what to do because, oh, no, no, dear, you can't make a decision for yourself. I mean, and I've used this analogy many times before, but I said, as opposed to Viagra, there are a lot of immediate risks to taking Viagra, and that. This is not something, oh, you might go blind 10 years from now. It might happen today. You might pass out and hit your head. All of these things, and men just go, yeah, but it's quality of life, and I want it. And there's no discussion about it, not to the level that we talk about hormones for women. And that to me is curious. What do you think?
No, I'm right with you. And my lens is unique because I get to lots of doctors take care of all genders, but like as urologists, we do hormones for both genders. We do pelvic surgeries for both genders. And the acceptable risk tolerance for women is much less on a very protective, I'm not going to let you make the decision, I'm going to make it for you. And an example would be mesh for slings. Now, some mesh in pelvises it goes poorly. 3% risk of side effects for mesh slings, right? So multiple countries pulled the slings off the market, making women who leak have no options. So you're going to not be able to leave your house, not be able to exercise, not be confident at work because we just got rid of this surgery for a 3% risk of mesh complications, which, by the way, weren't deadly, devastating, but not deadly.
Right.
Now, in men, we put plastic rods in your penis to give you an erection with a pump that goes in your inguinal canal. It's a very invasive surgery. When this goes bad, you've lost complete erectile function. You've got plastic rods sticking out of your penis. It's devastating.
Sounds like it.
We haven't pulled that off the market in any country.
Yeah. There is this, and I say, and I use this term and in a non-gender way, the patriarchy in terms of how medicine has just treated women generally. And, some of it has to do, and this is going way back to the whole thalidomide story about, and that sort of, I think, really took women out of the research era because it was like, the notion is that we are evaluated as subjects in terms of our reproductive potential. Either you're going to be pregnant or you are pregnant, and whatever it is that we must protect your reproductive potential to the exclusion of everything else. Now, that doesn't happen in menopause, but that attitude persists, about we have to preserve you as this baby making machine and we can't have anything go wrong there. And that's why I think so many women were not included in a lot of studies, because it's amazing that it took until 1993 before the government mandated that women be included in clinical trials. And we've learned a lot about how medications do not work the same way in women as they work in men, statins being chief among them. And I certainly grew up in the era where, everybody was supposed to take aspirin, baby aspirin a day to prevent heart attacks. Doesn't work like that in women. And so, until we get to a point where we realize that, and that women's physiology is different than men, and you can't just take one and extrapolate to the other and dose it down for weight, we're not going to really get to a lot of the answers that we need to get for women's health. So hopefully we're on the road now.
Yeah, I mean, I really want women, 10 years post-menopause or age greater than 60 to understand people will give you hormones after discussing risk and benefits. Not all people, but people. Right. And so I dove into the, because they say, well, the risk is higher. And I'm like, what's the risk? And I just saw a paper breaking out the increased risk of stroke in older women. This was WHI data. It's 44 out of 10,000 person years compared to 26 out of 10,000 person years. The risk of stroke is not, it's not like if you go on these hormones, you're going to have a stroke. It's pretty small. And then you look at women with heart disease. because a lot of people will say starting hormones with having pre-existing heart disease is a contraindication. It's a full stop. Well, there's actually multiple papers looking at hormones for secondary prevention. So these women had heart disease. We put them on hormones thinking this could be a secondary prevention benefit, kind of like a statin. The women did no worse than the women who aren't. So I'm like, why are we saying women with heart disease can't be on hormones?
Right. Even that elevated risk in heart disease was, from the Women's Health Initiative, was really isolated to women who were much older, and that little blip in the increase in heart disease only happened within the first year. After the first year, you went back to whatever your age-associated risk was. And I think that to put that in human terms for our listeners, the point is that as you get older, you may not get the benefit in the reduction of heart disease, but other than for a few cases that happen within the first year, you are not substantially increasing your risk, which is a totally different conversation. The earlier the better, you can decrease it, but as you're older, you just don't get as much benefit from the estrogen as you would if you started it 10 years earlier. And Kelly, I think that before, I always say, in the before days, in the olden times, that was really how we prescribed estrogen. Because back when I started, okay, so I can really take you back to the olden days, because when I started in practice, I inherited patients of doctors who there were two men, and they were in their 70s when I started. So this was 35 years ago. And they had women who were on hormones who were still taking unopposed estrogen. So these women had been taking their estrogen since the 60s. And I walk in, this little whippersnapper, and I was appalled. I was like, oh my God, you're taking estrogen alone? Well, a lot of women had hysterectomies, but even for the ones who hadn't had hysterectomies, and you figure that's the highest of the high risk of things not to do, is not to give estrogen alone in a woman who had uterus. And they were perking along, and they were 80 years old, and they're like, I'm fine. What are you doing? I'm like, no, you have to take this. So we learn a little bit, and we would add the progestin, and I'm sure some of them took it and some of them didn't. But nonetheless, the entire spectrum of how we've prescribed hormones, I've seen. And even when we started adding the progestin, and again, we didn't have micronized progesterone. So everybody got medroxyprogesterone. Everybody got it. I mean, it was like, it wasn't a thing, because we hadn't figured out how to give progesterone in a way orally that was active. And that's why it has to be micronized, because if you give it orally, it doesn't work. So we had to have the technology to even have the natural progesterone. So again, I've seen all of the phases as we've gone through this. And here's what the prevailing thought was before the Women's Health Initiative, is that we were giving hormones to women who were at risk for heart disease. And we were doing the same thing in reverse of what the Women's Health Initiative did. We had considerable data that said for young women from the nurses study that giving them hormones, they had a 30 to 50% decrease in their risk of heart disease. So what did we do? We said, well, then we should give it to women who are at risk for heart disease. And so we were just writing prescriptions like there was no tomorrow, because and the more risk factors they had, then so everybody was getting hormones, 70, 50, and everything in between. So again, having done that and seen that for 10 years before the Women's Health Initiative, now was that right? Probably not. That was what the Women's Health Initiative told us, that at least how to evaluate, based upon age. But we had been doing that, and I can, that was what I think that the investigators were trying to stop. That use of hormones just for everybody. And, we, as always, when the pendulum swings, it often goes too far in the other direction.
Yeah. Well, I think that the pendulum now being, what the United States Physicians task force. I can never say that long acronym.
I
Them saying
know.
we shouldn't give them this medication. We shouldn't give hormones for primary prevention of any disease. And people extrapolate that to say that you can't take this hormone for primary prevention of any disease.
Right.
And I don't think that that's what it means. I think it means as a nation, we don't throw everybody willy-nilly on the same drug. We don't do that with aspirin. We don't do that with statins, right? We do that with nothing. So I think it's very fair to say we don't throw the nation on estrogen to primary prevent any disease. But you get that woman, she's 48, maybe she's sailing through with no issues. But she's like, my mom broke a hip, got osteoporosis. I want the protective benefits for my colon, for my insulin resistance, for my musculoskeletal. I don't want the frozen shoulder. I think she can choose to be on hormones after a discussion with her physician. Just because we said the nation shouldn't be thrown on doesn't mean she can't make that choice. Would you agree with that?
I would agree with that. And I think that every person is different. And I think you look at that list of symptoms, and I think that we focus a lot on hot flashes because that's the visible part of menopause that we see and treat. But there are all those other things that are happening. And that's why I always laugh when someone gets through menopause and they say, then they didn't have hot flashes and they're feeling, fairly okay. And they'll go, well, you know what? I don't have to take hormones. I'm not at risk. I don't have anything.
Yeah.
I didn't go through menopause.
I didn't go through menopause.
I didn't go through menopause. I'm like, yes, you did. And whether or not you have visible symptoms, there are all these things that are going on in the background that you should at least be aware of what your risk factors are. And see, I'm a big proponent, and even with bone densities, I think bone densities, the current recommendation is that you get a bone density at 65. And I'm like, really? Because at 65, you've lost, the majority, that rapid phase of bone loss that happens in the first 5 to 6 years of after menopause, and you can't get that bone back. All we can do is hope to slow the train at that point. So I'm a big proponent of at least knowing at the time of menopause what your bone density is. If it's great, great. If it's not, then that's one more data point in this discussion about whether or not hormone therapy would be good for you. Because to date, hormone therapy or estrogen is the only medication that is approved for the prevention of osteoporosis. We don't want to wait until you've, had a wrist fracture or a hip fracture to try to figure out how to, sort of stick your finger in the dike and, save off this inevitable flood of bone loss that will happen. But, knowing what that is, and I think it's worthwhile, and they're available in most places pretty cheap. So even if your insurance doesn't cover it, it's worthwhile knowing what your baseline is. And I'm a big proponent of that.
I love that. Let's switch gears to the third hormone of menopause. And I always joke because I'm like, how many hormones we have? We have many, 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 many.
Many.
We say there's 3 for menopause because that's the commercially available hormones that we have. Right. But it's like, who knows? In 10 years, we're going to discover this other hormone that, goes down in menopause and will prevent all blindness or something like that. But for the current state, we got 3. We got estrogen, progesterone, and then we've got testosterone. Give me your thoughts about, how I feel about testosterone.
I do.
But tell me your thoughts on testosterone. Where are we in that discussion of it being important for women, and what are your hopes for that?
You know what? I think that there are a few things that have hampered our understanding of how important testosterone is for women. And one is the classification of the medication itself. It's classified in the same category as if you were taking morphine, a highly addictive medication. So there's that. It makes access a problem. It makes doctors leery about prescribing it because they fear that they're doing something dangerous or illicit. There's that. And I think that we lost a huge opportunity a few years back when it came up in front of the FDA to actually approve a testosterone preparation for women. I mean, it exists in the world. I think the only place that, and then maybe you know this better than I, Kelly, but Australia is the only place that I know where there's actually an FDA type approved medication for women.
And South Africa. South Africa just happened.
See, really, we're behind Australia and South Africa. Is that where we want to be?
Yes, ma'am.
But we had an opportunity and they turned it down. And again, this is where I think that there's not medicine involved. I think there's some politics involved, because if you take a medication and you are the indication for it is improving sexual function in women, again, here we go back to that old bugaboo: women and sex. Ooh, why would we want to make sex more enjoyable for women? That when that indication was what it was going up for, and they turned it down, you know, again, we don't have to go into that, but you know what I mean in terms of how we're policing women's bodies and what we can and cannot do. However, there are many other benefits to testosterone in women that we haven't fully elucidated, because, again, the research,
Hmm.
let's do it. We know that it helps with bone density, muscle mass, may help with some other, with some brain function things. There's a lot of other things that I think that, we have stood still in terms of doing the research on testosterone in women. So, right now we think of it as this only improving sexual function, and I think it does much more than that. And hopefully, again, now that, people like you are out here raising the issue about testosterone, that maybe we can get some research and go back to the FDA and see about getting that approved. But that's the long game.
That's the long game.
That's
Yep.
the long game.
And getting the DEA off to allow more
Yeah.
access, especially in the telemedicine world, right?
Right.
Telemedicine and the
Right.
DEA, that's one of the big barriers. So they're doing studies for sarcopenia and mood in Australia right now. There's some heart protective benefits, and there's a lot of data showing protective against breast cancer. There is some breast health stuff with testosterone. That's super exciting. I'm like, why aren't people looking at that more? This is a feared disease. So yeah,
Right.
I think we're at the beginning, and I'm excited to be part of the story.
Right. And I think that, again, maybe, I'm not sure that, certainly in my limited amount of career time that I have left, that I will see it. I'm not sure of that. But, for your generation and for those that come after, at the very least, being able to raise the issues of that, we would have the same questions about women's health forever. No one has found them interesting enough to study. And, I will not blame researchers, because at the end of the day, they're going to do the research that they get paid to do.
Hmm.
And if no matter how interesting it is, if you can't get a grant or someone to support your research, then you're not going to do it. I mean, at the end of the day, people aren't in this for simply altruistic reasons,
Right.
you know, um, but we've got to change that paradigm, and we've got to say women's health issues and preservation of women's function as we age should be a priority. And why wouldn't it be? I mean, it saves us money as taxpayers to make sure that we are not just treating diseases, that we are preventing disease. And we've got to shift that focus a little bit more on the front end.
100%. Let's talk a little bit about African American women, minorities, women who are economically disadvantaged. What additional struggles do they have with their menopause transition?
Well, when you're talking about African American women, and this includes any economically disadvantaged and minority women, so we're African American women are clearly the most commonly commented upon because of their consistently poor health outcomes. But when it comes to menopause, this is what we know, which is contrary to what I was taught when I was in medical school. Black women have more severe symptoms. They last longer. That menopausal transition, which we thought was 4 to 7 years, for African American women is more like 10 years. They are more likely to have symptoms that persist even after menopause, not just during the transition. And their menopause really starts earlier, about almost a year earlier. Hispanic women are somewhere in the middle, and probably the women who do worst of all are Native American women. It's just not enough data to really prove that. So these are women who are most at risk for all of the things that we talk about, the long-term health risks for menopause, such as cardiovascular disease, Alzheimer's, type 2 diabetes, obesity, sleeplessness, mood disorders, all of that. And Unfortunately, because of what we think or what we've really been taught about what African American women experience during menopause, they are least likely to get a prescription. So even a Black woman who comes in complaining to her doctor of these symptoms is only half as likely to get a prescription. And even once they take that prescription home, they're only half as likely to take it. Because this is something, and I'm sure you know this too, Kelly, is that if you want people to be compliant with whatever treatment your treatment plan is, your medication, if you explain to them why it is important, you will get more buy-in on whatever it is you're suggesting. And I think there's not enough conversation around these long-term health issues for African American women. And all that's really percolating out there in the atmosphere is it increases your risk of breast cancer. Oh, it's not good for you. You're going home with a prescription for something that you think is dangerous. And so you're afraid to take it.
Mhm.
And so we've got to do some education really on both sides. We've got to educate our, physicians to say that no, that is not true, that Black women, because they weigh more, are not at risk for menopausal symptoms. No, it is not true that Black women, just because of the fact that they're Black, are not at risk for osteoporosis. I mean, these are things that I was taught. Oh no, you don't have to worry about that because, all of this sort of faulty logic about why Black women do not suffer. And there is also, and this is my role out here in the world, is to really try to educate women and Black women in particular to the notion. I want you to sign on to the notion that you do not have to suffer. Why do we as women just assume that suffering is our lot in life? Oh, well, you get old and you feel bad, and that's what happens when you get
Mhm.
old. Or, I'm not sleeping. And we take a lot of that on, and I think that it readjusts our baseline, and it makes us accept something that is far less in terms of quality of life than what we should expect. So that's my job. I get out there and I'm shouting from the rooftops, and and I know you work on the vaginal estrogen part, which we all agree every woman should have.
Mhm.
Um, but it's also understanding that, suffering should never be your resting place. If you are not your best self, then we need to go figure out how we are going to get you to that space. And the sooner we start on that journey, the better you're going to end up. Because let me say, as I said, I'm not ashamed to say it. I'm 65 years old. I'm doing great. I feel good. And if I don't feel good, and that's my clue that something is amiss.
Mhm.
Otherwise, and I write about this in my book. I talk about this sense of interoception, which is that internal sense that you have when everything feels normal and right. You're balanced and centered. And it's funny because I think about it this way. I said, normally you're not aware of your body parts. You're just walking around the world and, I'm not thinking about my foot or my hip or anything like that. When you are aware of things, that's your signal. That's your body trying to tell you that something is wrong here. Pain and discomfort are potent signals to you that something needs to be addressed. And when you blunt that sense by just taking feeling bad as your baseline, then you ignore things that you should be paying attention to.
I love that. What advice, and I want to dive into your book now because I think there's so much great advice in this book. But people say, how do I ask my doctor for, we'll throw hormones in here for this example.
Mhm.
How do I go ask my doctor to try something? And I've kind of got my spiel on what I think, but I want your opinion on like, what's the best way? Because you're afraid you might not even know this doctor. There's a power differential. They're in a hurry. What's the best way to advocate for yourself in trying something new, say like hormones?
You know what? It's funny, when we talk about hormones, this is the only time that I think that this conversation comes up that you have to go in and advocate for your doctor, and your doctor may or may not give them to you, right? Think about all the commercials you see on TV all day, every day about these medications.
Ask your doctor if it's right for
Drug
you.
companies have got this down. They're like, yeah, I want you to know about it, and I want you to go in and ask for it. Now, the amount of pushback that you get from your doctor about these drugs, expensive, who knows what you're asking for drugs, you don't even know what they do. What is that? I don't know what that, I don't even
Those
know what
people
that.
looked happy on that commercial.
Exactly. I want that. So the notion that patients go in and talk to their doctors and ask for things is not a novel concept. They've been pushing you to do that. It's only when we're talking about hormones that people are giving considerable pushback. So this is the advice I would give. And I talk about this and I go through the options of a lot of things, not just hormones, but I talk about, fibroids and, why would you have a hysterectomy versus a myomectomy? These kinds of things. The more you know going into that conversation, you're already prepared. You're like, okay, I've thought this through. I know what the pros and cons are here. The same is true of hormones. I've looked at this. I've read about what it means, what I'm at risk for. So you're going into that conversation, prepared. And you are not going to take no for an answer. Or at the very least, if a doctor tells you no, or sometimes you want to take things and it's not a good idea. I mean, let's be real about that. You can't, there's some things you shouldn't have. But at the very least, make sure that to your satisfaction that doctor explains to you why that is not a good idea. A blanket no, you should never walk out of there with that. As I say, if someone doesn't have the time to explain it to you, then you probably need a new doctor. But let me say how you can be efficient. And this is something I talk about in my book, is I say, learn how to be a good storyteller. Because the more prepared you are, the more information you can give your doctor coming in and knowing what's important, then we can skip a lot of all that, and then last Tuesday,
Yeah. Yeah. And
it
once you, on the doctor side, if you start telling me about your cousin's mailman who had a dog that ran away, like, stay on point. This is about you.
Exactly.
Yeah.
Exactly. And that's about just being prepared for your visit. And if you understand for that, you have 15 minutes when you come in to see a doctor. That's what you're slotted for. I don't know what people think, but you got 15 minutes, and a good 6 minutes of that time is spent getting undressed and dressed. So, and then you pick, okay, blood pressure and weight. You've got about 5 to 6 minutes of FaceTime with your doctor. So you can't afford to waste time, and you can't, like I said, so the more you know going into that, I got it. If you are having many problems, then I think that don't try. The best thing you can do for yourself is don't say, I'm going to do an annual exam and I've got to do all my preventative stuff that my doctor needs to talk to me about. And then, oh, by the way, because now you've got 30 seconds at the end of that visit to talk about what you came for. Sometimes you're just going to have to make another visit. You're going to have to discuss the thing that you want to discuss. Because if you're talking about hormones, that's not a one and done 2-minute conversation. Have your annual exam. Make sure you've got all the stuff, all your ducks are in a row. And now you come back. And when you make an appointment like that, and this is why telehealth is so helpful, because the next appointment doesn't require you to get undressed. It doesn't require you to do anything other than talk to your provider about the symptoms you're having and what the possible solutions are. So that's what I said. If the number one, be prepared. Number two, if you have more than one thing to talk about, make another appointment. I know it's unwieldy and you got to take another half day off from work, but you're not doing yourself a favor by trying to fit a complicated conversation into 30 seconds.
I love it. Another very practical thing that I loved seeing in your book is know what medications you're on and why you're taking them. So many people, and I joke with them now because it's so crazy to me, but I have a doctor lens, but it's like, I don't know what I'm on. It's in the computer. And then they don't know why they're on it. And I'm like, let me get this straight. You put something in your mouth and you swallow it and you don't know what it is. And then they're like, oh, yeah, I guess I do that. But it's a kind of a blind faith. And a doctor told me to take this. I must take it, right? Yeah. But like, I can't evaluate if you can stop your blood thinner or not for a surgery if I don't know the reason why you're on the blood thinner. Right? Like knowing why you're taking these medications.
Right. But you know what, Kelly? That takes time.
It does take time.
That takes time. And most doctors, like I said, they're trying to get you in and out, in and out. And that is the reality that I want people to understand, is that nothing in the direction that we're going right now is going to make it easier for you, or make it more efficient for you, or make it more personal for you. Just understand that. I mean, doctors are under, and I'm going to give a little bit of a shout out here to my colleagues, because and I just left, clinical practice. So I understand the pressure that they're under, with decreasing reimbursements. You've got time. A lot of practices have been bought by, venture capital groups, or you work for a hospital, and they are telling you how many patients you're going to see in the course of a day. You don't get to decide, or you pay severe consequences in terms of compensation. That's the reality, So a lot of times your doctor isn't trying to be mean or give you short shrift, but they are on, they're like, get going, get going. And so that's why when I wrote my book, I said this. I said, I want you to understand that you have way more control in this interaction than you think, because it used to be a certain way 30 years ago, where my doctor knew, and my doctor knew me and knew what I was, what's going on in my life and whether or not this would be a good idea. Don't expect that that's going to happen. Just don't even expect it, because you may see one doctor this time, particularly in primary care and even OB-GYN, somebody else the next. There's a churn that's going on in medicine and medical personnel that used to never exist. I worked in one practice for 30 years. Nobody's going to do that anymore. That's just not going to happen. And certainly not in the same way. So you have to understand that that's the new reality. They don't have me. That was one of the titles for my book that I considered was No One's Coming to Save You. And my editor said, well, that's a little dark. Go a little something more upbeat for that. But it's
like,
just
true, but that's not going to sell.
True, but okay. But that's the reality. And that's sort of why I wrote the book, is to really give you the practical tips, the information, the ins and outs, why we do the things that we do, and one of my favorites is the message that you get when you call a doctor's office, when they say, if you're having a medical emergency, hang up and dial 911. We didn't used to say that. In the before times, Kelly, that was never on our answering machine message. And I figured, I was like, why did we start saying that? It just, it caught hold, and now it's on every doctor's answering machine.
Yeah. I always thought it was a medical legal thing.
It wasn't. It wasn't until it was.
Right.
Because in the old days, and, I'm really going to sound like an old person talking to you, but Kelly, I worked before we had cell phones, we had pagers. You would have your pager on, and when you'd get a beep, you'd have to pull off the side of the road, go to a payphone, call the answering service, because there was no way to even have that. You had to listen, get a message, call them back, whatever. I mean, it couldn't have been more difficult to call a patient back, and yet we did. And now, which is amazing to me, the more technology that we have, you can just get a page right here, get the message that the patient says, blah, blah, blah. Why can't we call that patient back? And that's sort of where that whole hang up and dial 911 is just try calling your internist about anything and expect to get a call today. And again, I'm not making a value judgment one way or the other. Yes, I am. But I'm just saying that that's why that message is there, because you can say, if you don't get a return call, you can say, well, I told you to go to the emergency room. And sometimes all you need is someone to give you some reassurance.
Yeah.
Because 9 times out of 10, you don't need to go to the emergency room.
Yeah.
I mean, let's be real about it.
Totally. One more thing I love that you put in your book, and I want to make sure I get to before the end of the hour, is debunking the risk of breast cancer is not 1 in 8. And
Yes.
what sort of marketing decided to put the inaccurate fear of our breast cancer risk? And you spelled it out. You said each decade, this is your risk. And where the 1 in 8 came from is if you add each decade up, which I don't think we're allowed to math that way. I'm not sure that that's even
You know what? I have to tell you, I can't take credit for that. I never, I've said that for years. Yes, your lifetime risk of developing breast cancer is, 12.5%,
But
one in
it's
eight.
not.
Not yours, not an individual's risk
Not an
is not.
individual's.
Some are higher, some are way less. But I got that. I never thought about that until I read Avram Blooming's book, Estrogen Matters. And I was like, well, I never thought of it that way. And what that means, for those of you that don't know what Kelly and I are talking about,
Thank you. Thank you for breaking this down.
if you live long enough, okay, if your risk for developing breast cancer goes up with each decade of life.
Because you're getting older.
Because you're getting older.
And you've been around longer.
It's not because of estrogen. It's not because of whatever. Because remember, the majority of women who get breast cancer are postmenopausal. They have the least amount of estrogen they've ever had in their system. And it is an aging thing that goes on. So it goes up with age, right? Well, if your risk is, and I can't remember exactly the numbers, but bear with me. If your risk of getting breast cancer at 40 is 1 in 100, if your risk from 40 to 50, if your risk of getting breast cancer between 50 and 60 is 1 in 50, and it goes up with each age, then it might be 1 in 25. To get to 1 in 8, you have to add up the risk of getting breast cancer in each decade to get to that number. Even when you're 80, the risk of getting breast cancer is still only like 1 in 20. It's never 1 in 12 for a population statistic. And that's one of those things where you can just sort of make it sound scarier than it is. But because we all know women, and everybody knows someone who's had breast cancer, it sticks with you in a way that you think that your individual risk is 1 in 8. If you live, your highest risk is still less than 1 in 8. And here's the other thing that I think is really important for women to know, and that I talk a lot about, and that is when you're talking about statistics, population statistics is everybody. Your risk of getting cancer is 40%. I mean, risk of population statistic. All people in the world will get cancer. Well, a lot of that is skin cancer. Well, a lot of that is, there are things that you may or may not be at risk for. That's just a general number. So whenever you're trying to say something and they're telling you a percentage, it is always important to know, okay, well, that's the percentage. What is the absolute risk? What are the numbers underneath that? Because if I told you had 100% increase in developing breast cancer because you ate toast for breakfast this morning, if my risk was 1 in 100 and now it's 2 in 100, well, that doesn't sound nearly as scary as saying 100% increase in risk. And that's why I said, be careful when you read statistics, and headlines like those kind of numbers, because they sound scarier than the real numbers.
Yeah, I love when we can educate. I mean, math to me was like a class to get into medical school, right? But math to my husband is a way of seeing the world. So I don't think most people, unless we kind of just start trickling this in with podcasts and stuff of it's not actually 1 in 8. How they got to 1 in 8 doesn't actually make sense.
Right.
And you're not going to be living in your 40s and 50s and your 60s and 70s at the exact same time.
Right. Ever. You're not going to get breast cancer in every decade of your life.
Right.
There's that.
Yeah. I love it.
But you know what? But the funny thing is that even though those of us who could do, we've done calculus, so we know how to do some advanced level math. Statistics still befuddle us all. Yes. Let me just say this. Even when I'm reading a paper, I'm sitting there, I'm like, what a chi-square, whatever. I don't even know what you're talking about. It's very confusing. And that's why I said sometimes you need some help for someone to just sort of explain it.
Lay it out.
I need them to explain to me sometime.
In a lot of papers, because I look for it now, I want an absolute risk and they don't publish it. So I have to wait for the paper analysis by the people who do know statistics to then tell me what the absolute risk is. So a lot of times that data is not even there, even though we know that's the better thing. Dr. Sharon Malone, I'm so glad you're here. Her book, Grown Woman Talk, is out. By the time this podcast is out, it's out now. You can pre-order it also. But it's coming out April 9th. And the world is all the better that you're in it and you wrote this book. And that you're that you agreed to be my friend.
Oh, absolutely. Absolutely. You can't get rid of me now, Kelly. I'm here.
Thank God. I'm not going to try, but good to know. Thank you so much for joining me today. This has been an amazing hour, and I think people are going to get a lot out of it.
Thank you, Kelly.